Hi there, everybody, and welcome to the July edition of our webinar series. This month, we're going to be talking about traumatic brain injury and intimate partner violence. But first, before we get started, just a quick warning that some of the content you're about to hear might be upsetting. So please practice good self-care and step away if you need to do that, or pause if you need to do that. And also, we'd like to acknowledge that the Women's Resource Center is located on Treaty 2 territory, and we also operate on Treaty 1 territory, which are the lands of the Anishinaabeg, Cree, Oji-Cree, Assiniboine, Dakota, and Dene peoples, and the homeland of the Métis Nation. So just a little bit of a roadmap of what we're going to be covering today. We're going to be going over what a traumatic brain injury is. We're going to be talking about how traumatic brain injury intersects specifically with intimate partner violence. We're going to be talking about a really interesting traumatic brain injury resource in Manitoba, more general resources, and then of course our contact information will be at the end of the presentation. So traumatic brain injury is defined by the Brain Injury Association of America as an alteration in brain function or other evidence of brain pathology caused by an external force. So an alteration of the structure or function of the brain by something that happens outside of the brain, so a physical force outside of the brain. And in Canada, actually, TBIs are one of the most common types of neurological injury, just next to Alzheimer's disease. TBI is the leading cause of global disability, and approximately 2% of Canadians have experienced a TBI in their lifetime. Every year, there are approximately 18,000 hospitalizations for TBI across Canada, but there are likely many more TBIs that do not get medical attention, so that number is a lot higher than 18,000. There are two aspects of TBI. So there's the initial injury that caused it, that external force, and there's the changes that occur after the TBI. So the alteration in the structure and the function of the brain that's caused by that initial injury. So there's two aspects of TBI that are important to keep in mind. You might have noticed that within the last few years, traumatic brain injury has been talked about in the media and in society quite a lot, but it's been in reference to only a couple of specific types of instances of traumatic brain injury. So typically it's talked about with reference to military personnel who have sustained TBIs in the context of sports injuries, specifically like football and hockey, where there's a lot of like those contact sports where there's kind of a lot of potential for injuries and head injuries specifically, and also one-off events like car accidents or, falling from a height, things like that. And it's also important to note, and this is something to keep in mind as we go forward, that a loss of consciousness is not a requirement for a TBI to have occurred. So just because somebody didn't get knocked unconscious by the external force that happened to them, that doesn't mean that they don't have a traumatic brain injury. That's important to keep in mind as well, because that's a common misconception, is that, oh, somebody didn't lose consciousness, so their brain must be okay. That's not necessarily the case. There's the one main way that brain injuries are measured is in a medical setting is the Glasgow Coma Scale, or GCS. It's one of the most common measuring tools that we have in a medical setting to determine the severity of traumatic brain injuries. And what it is a 15-point behavioral scale that measures the level of consciousness immediately following a TBI. So if somebody scores 8 or less out of 15, they have a severe TBI. If they score 9 to 12 out of 15, they have a moderate TBI, and 13 to 15, they have a mild TBI. And approximately 80% of traumatic brain injuries that present for medical care are classified as mild. And oftentimes mild TBIs don't even show up on neuroimaging scans, so like CT scans, because the changes that happen in your brain are too subtle to be detected. And in addition to that, there might not be any physical signs that a TBI has occurred. So there might not be any visible injury or anything like that to indicate that a TBI has occurred. And also symptoms can appear immediately after a TBI, or sometimes they can even take days, weeks, or even months to show up. And this here is a list of typical symptoms. So headaches, dizziness, depressed or tearful behavior, being irritable or easily angered, frustration, restlessness, poor concentration, sleep disturbances, forgetfulness, taking a longer time to process thoughts. And that's not a full exhaustive list of symptoms. That's just kind of what is most often seen in a medical setting. And the reason that I outline all of this information is to show how complicated it can be to diagnose TBIs, especially given that most TBIs are classified as mild, and assessing mild TBIs can pose issues given that, again, they don't show up on those neuroimaging scans all the time, and there might not be any physical signs. So just to say that just because it doesn't appear that somebody may have a TBI just by looking at them, that doesn't mean that they don't necessarily have one. So in the context of TBI and IPV, or intimate partner violence, intimate partner violence is actually a really common source of traumatic brain injury. And this quote here is from a paper published in 2020, saying that emergency room records show that 38% of IPV victims who received emergency medical treatment exhibit significant head, neck, and facial injuries. And it's estimated that this number is much higher, with 60 to 92% of surviving female IPV victims receiving facial, head, or neck strangulation injuries. So that kind of goes back to what I was mentioning before of how even though there are 18,000 hospitalizations in Canada for TBI every year, because not everybody presents to a hospital when they've had a TBI, that number is likely much higher. The same goes with IPV. 38% of IPV victims who have gone to the emergency room have exhibited signs of TBI, but likely that number is much higher because not all people who experience intimate partner violence present to the hospital for medical care. And also it's important to note that when we're talking about TBIs sustained from instances of intimate partner violence, we also include anoxic brain injury from attempted strangulation within the typical definition of TBI that I mentioned before, because attempted strangulation is extremely common in situations of intimate partner violence, just over 50%. And anoxic brain injury is when the oxygen levels to the brain are cut off for a significant period of time, and that can cause changes in the structure and function of the brain as well. And it's important that we include that as well because it's not included in the typical definition of TBI, but in the context of intimate partner violence, we want to make sure that we're including that. And as we know, domestic violence and intimate partner violence are extremely underreported. And as I mentioned, so are traumatic brain injuries that are sustained from intimate partner violence. It's also important to differentiate TBI from IPV and TBI sustained in other ways. So those military service TBIs, sports injuries, and one-off events like car accidents, they're very different for a number of reasons. One being that TBI from IPV is rarely a single head trauma. Many survivors of IPV sustain multiple TBIs, whereas in those other ways that I mentioned, playing sports or one-off events like car accidents or military service, it's much more likely to be a single head trauma or a much lower number of multiple, whereas survivors of IPV can sustain half a dozen, upwards of half a dozen TBIs from a single instance of intimate partner violence. Also, when we focus on military personnel, sports players and trauma patients, the focus is on, quote, young males in relatively good physical health and without the physical and psychiatric comorbidities associated with intimate partner violence. And that's from a paper published in 2011. Typically, intimate partner violence is experienced by women. And if somebody is experiencing intimate partner violence, and sustaining a TBI from that. Again, it's typically multiple instances of violence that they're experiencing. So they may not be in excellent physical health if they've experienced other instances of violence, and they may also have other physical or psychiatric conditions that are associated with intimate partner violence, like anxiety or depression or PTSD, that can really affect how a traumatic brain injury impacts somebody. TBI from IPV also comes with, like I mentioned, sustained psychological stress. As we know, intimate partner violence causes things like anxiety, depression, PTSD, and again, those really impact how somebody is able to react to a traumatic brain injury, how it affects their brain and the symptoms they may experience afterwards. And also the injuries themselves differ. TBI from IPV, you often have a lot of physical injuries to the head, neck, and face. Sometimes they may be hidden injuries. So they're not always the same. Like a car accident TBI is probably going to look very similar across all TBIs sustained from car accidents, but in TBIs from IPV, that's going to look different case to case, and that's important to keep in mind as well. And in a study of the severity of TBI sustained from IPV, it was actually found that 68% of the sample had at least one mild TBI, 10% had moderate to severe, and 27% sustained a choking-induced anoxic event. It's from that paper published in 2011 that I mentioned before, and it highlights that the prevalence of mild TBIs and why it's important that we pay attention to mild TBIs and not just those moderate to severe ones. And also it highlights the importance of including that anoxic brain injury element, as there's a significant number, as you can see, of people who experienced an anoxic brain injury. We do want to stay away from the term choking, as that kind of implies a different type of experience than strangulation, which is really what it is. Strangulation implies violence. So that is typically what folks are experiencing when they're experiencing an anoxic brain injury, is something that's coming from violence. So after experiencing a TBI, people may experience post-concussive syndrome, or PCS. Headaches are extremely common in folks that have experienced TBI, especially TBI and IPV, because those injuries typically are multiple, as I mentioned, and also PTSD. And again, especially in the case of TBI and IPV, PTSD is something that is already associated with with IPV, and that can be compounded by a traumatic brain injury as well. So just to go over briefly what post-concussive syndrome is, post-concussive syndrome, or PCS, is a cluster of symptoms that can last up to 3 months after a traumatic brain injury, and it must include at least 3 of the following symptoms. So disturbed sleep, anxiety or depression, dizziness or vertigo, apathy or lack of spontaneity, headache, personality changes, irritability or fatigue. Somebody who has at least 3 of those symptoms may have post-concussive syndrome, but also just because somebody has some of those symptoms doesn't mean that they do have post-concussive syndrome. It's up to a medical professional to be able to diagnose that. We want to make sure we're not self-diagnosing, because that can compound anxiety as well for folks a lot of times. Post-concussive syndrome is something that's diagnosed in a medical setting. As I mentioned, headaches are extremely common, of course, when somebody experiences a traumatic brain injury. That same study from 2011 cited headaches as one of the most common issues experienced by survivors of IPV-related TBI. And it's estimated that 30 to 90% may experience headaches. But again, it's difficult to know what that number is for sure because of how underreported IPV is and how underreported TBIs from IPV are. So that's why that range is so wide. And finally, PTSD. Again, we already know that many who experience PTSD from IPV that's already very common. Rates may be up to 92% there. And somebody who is experiencing PTSD will have a different experience of a traumatic brain injury, and it can affect them in different ways than somebody who has not experienced PTSD. I want to talk about a really interesting development here in Manitoba, actually related to traumatic brain injuries. So PanAm Clinic in Winnipeg is now running a pilot project called the Intimate Partner Violence Traumatic Brain Injury Pilot Clinical Pathway. I know that's a long name, but we'll explain a little bit what it's about. And this is a way to recognize how common IPV-related TBIs are and provide a specialized pathway for care so that folks are able to get the care that they need when they experience or if they experience a traumatic brain injury from IPV. So this program connects patients with concussion specialists and brain injury specialists that are able to follow them and follow their care for a long period of time, and provide that holistic care model. They're able to recommend other services that may be useful for the person. They're able to do testing. They're able to kind of keep up with the patient and monitor their progress, and ensure that they are healing from that traumatic brain injury in the most effective way possible. So to be eligible to participate in this program, there's 4 criteria. They must be a youth or adult diagnosed who sustained head trauma that's directly caused by IPV, including those with head injury, concussion, or structural injury, or injuries secondary to strangulation. So there again, highlighting how important it is that we include those strangulation injuries, those anoxic brain injuries. The second criteria is they must present to Health Sciences Center Emergency Department within 10 days of the date of the injury, because within those 10 days is the best time to be able to diagnose a traumatic brain injury. So the patient has to go to HSC emergency department to be assessed in the emergency department. So that's number 3. However, if somebody who has experienced a traumatic brain injury and also sexual assault presents to the sexual assault nurse examiner program in HSC, the sexual assault nurse examiner program also has the ability to refer people to this TBI clinic at PanAm. So that one's not mentioned on the website, but that is also true. And the person must reside in Manitoba to be able to be eligible for this program. And if you would like more information or to just have a look around at what PanAm does, I've linked their website here. And I'm also going to link this website as well as all of the other resources I mentioned in the description of this video. So if you want to just like scroll down, they'll all be there. This is what the website looks like, and you can check out how they work, what this particular clinical pathway is about. They've got an information sheet on traumatic brain injury that really breaks it down and can be useful. So feel free to check that out if you're looking for more information on this particular injury pathway. So I'd like to talk about a few other resources related to TBI from IPV specifically, because I feel like this is something that is not discussed, because again, typically TBIs are discussed in terms of those sustained sports injuries and military service and car accidents and things like that. So I think it's important that people have awareness of the resources that are available for traumatic brain injuries specifically related to intimate partner violence. So I mentioned the Glasgow Coma Scale, or the GCS, sorry, that's misspelled, but that's the typical tool that is used to measure the severity of brain injuries in a medical setting. However, this tool is not calibrated specifically for IPV-related TBI, which is important that it is, because as I mentioned, IPV-related TBIs are a lot different than TBIs sustained from other sources. And unfortunately, there are currently no tools specifically validated for assessing IPV-related TBIs, but 2 existing measurement tools have been adapted. So there's the HELPS tool and the Ohio State University TBI identification method, which I know is a mouthful, so we've got the shortened version there, but we're going to go briefly over both of those resources so you can have a general idea of what they look like. And then also, again, going to be linking them in the description of the video below so that you can have a look at them at your own leisure and kind of get a better, closer look at them. So the HELPS tool is, again, one that's used in the medical setting. It asks 5 central questions to make its assessment, and it follows the acronym HELPS. So have you ever hit your head or been hit on the head? Were you ever seen in the emergency room, hospital, or by a doctor because of injury to the head? Did you ever lose consciousness or experience a period of being dazed and confused because of an injury to your head? Do you experience any of these problems in your daily life since injury? And then it kind of lists the typical symptoms of TBI that we discussed before, so like dizziness, fatigue, depression, those kinds of things. And the final question is, any significant sicknesses? So again, this is not a perfect tool because it provides a score, but it also emphasizes loss of consciousness, which, as we mentioned, a loss of consciousness is not a necessary condition for somebody to have sustained a TBI. So the scoring kind of goes like this. A HELP screening is considered positive for a TBI when the following 3 items are identified. So an event that could have caused a brain injury, so they have to say yes to H, E, or S questions. A period of loss of consciousness or altered consciousness after the injury, or another indication the injury was severe, so yes to L or E questions, and the presence of 2 or more chronic problems listed under P. So that were not present before. So again, not a perfect tool because in order to be considered positive for a possible TBI, they emphasize loss of consciousness or altered consciousness, when again, that is not a necessary condition for somebody to have sustained a TBI. You can have a traumatic brain injury without losing consciousness or having altered consciousness. So it's a useful tool, but it's not perfect. The other tool, this is just a screen grab of what the form looks like, and also the link is here and it'll be in the description below as well. The second tool is the Ohio State University TBI Identification Method, or the OSU TBI ID. This is a tool that's a form, and it also uses a short interview process. It is a little lengthier and it does go a little bit more in depth. And it does not provide a score in the same way that the HELPS assessment does. It does give you more room for providing examples and context. It's about collecting and recording information rather than making a formal diagnosis. It's just to kind of help somebody get a better idea of the event that somebody has experienced and how it's related to traumatic brain injury and intimate partner violence. So it's here, it asks questions like, have you ever been hospitalized or treated in an ER following a head injury? Have you ever injured your head or neck in an accident? Have you ever injured your head or neck in a fall or from being hit by something? Have you ever injured your head or neck in a fight from being hit by someone or from being shaken violently? So that's the one that's going to pertain specifically to intimate partner violence. In your lifetime, have you ever been nearby when an explosion or blast occurred? That one is more specifically tailored for military. Then you go on to section 2. It asks about loss of consciousness. But it doesn't really emphasize it in the same way that the HELPS assessment does because it doesn't provide a score based on how you answer this question. And then step 3, have you ever had a time in which you experienced multiple repeated impacts to your head? And again, it highlights the history of abuse. So this one's going to be more specific to the intimate partner violence context. And then it asks the patient to kind of describe it as best they can. And then there's spots here at the bottom for those examples and more technical information to be entered. The link is on the side here for somebody to have a look at if you would like to, but again, also going to be linked in the description below. And the final 3 resources that are more informational, there's the Brain Injury Canada website, which has a lot of information, statistics, that kind of thing on brain injury in Canada. the Brain Injury Association of America, again, which is a lot of similar information statistics on brain injuries. And both of those websites have sections that are specifically related to IPV-related TBIs, which is extremely useful. And finally, there's a website called Abused and Brain Injured that's run by the ABI, or Acquired Brain Injury Research Lab at the University of Toronto. They have an excellent website because they have the ABI Toolkit. It's an acquired brain injury toolkit that provides a resource library of research on traumatic brain injuries, research and tools for people who have sustained IPV-related TBIs. So that's really excellent resource as well. And they have a ton of information on that website if you just like to pick through it at your leisure. Again, all of these will also be linked in the description below the video. And that's what I have for you today for the month of July. As always, please feel free to contact us with any questions that you might have. Our contact information is here, and we will see you again in August.